Share my screen. Oop. Are you seeing my screen?
Yes, I see pretty birds.
Okay, perfect. All right, and when I do this, I think I may lose seeing all of you. So if people, oh yeah, I can still see. Okay, perfect. Awesome. Well, thank you so much. So I'm Kelly Young-Wolff, and I'm a licensed clinical psychologist by training. I have my collaborator and co-author, Deb Ansley, on the call as well, and she's going to join us for the question and answer session. So we're really excited to be here with you today and tell you about some of what we've been learning about the health risks associated with prenatal cannabis use. And one of the things that tells us why this is so important is this recent report that came out by the American Heart Association that really highlighted two particular time periods that are the most important in terms of cannabis exposure, and those are cannabis in utero and cannabis during adolescence. And so, we're learning more about the potential health risks of cannabis use during pregnancy. And I'm sure many of you know that the American College of Obstetricians and Gynecologists recommends that women who are pregnant or contemplating pregnancy should be encouraged to discontinue marijuana use, and those who are using should be counseled about concerns regarding the potential adverse health consequences of continued use during pregnancy. But, we've been kind of
This morning.
research on prenatal cannabis use for about the last 10 years. And especially when we started doing this work, we didn't really know a lot about trends in use. The health impacts were not really clear. And we didn't have a lot of information about how to talk to our pregnant patients about cannabis use during pregnancy. So those were the things that we really tried to address with our research. And our studies all take place in Kaiser Permanente, Northern California. So if you're not familiar with us, we are a large integrated healthcare delivery system serving about 4.6 million members in the Northern California region. We have over 50,000 pregnancies a year, and our patients are diverse and representative of the Northern California population. We're an integrated healthcare delivery system, and we have a robust electronic health record, which is fantastic and also allows us to conduct really interesting research. We also have our Kaiser Permanente Northern California Early Start program, and this is the program that Dr. Deb Ansley is actually the medical director of, and so you'll have her expertise here during the question and answer session if people are curious about this program. But it is an award-winning perinatal substance use screening and intervention program that's directly integrated into prenatal care. And as part of this, it includes universal screening for prenatal substance use at about 8 to 10 weeks gestation. So when patients come in to prenatal care for their first visit, they're asked about their self-reported frequency of substance use, including cannabis. And then they're also given a urine toxicology test to which they consent. And part of why we can do that is that in California, prenatal substance use is not criminalized or penalized as it is in many other states. And because of that, and because we have this early start program, we are able to do this, and we offer all of our patients who are using any amount of substances during pregnancy further assessment with a licensed mental health clinician, where you can really learn more about what's happening with that patient. They get education, and then they're actually offered counseling that co-occurs with their prenatal visit. So it's kind of integrated into their prenatal care. And so this is a clinical program. We get all of our data. The point of this program is to help our patients, but it also provides really rich data for research. And so today I'll talk about a couple of our electronic health record-based quantitative studies that use these large, populations of pregnancies in our healthcare system. But I'm also going to bring in some quotes from our patients based on focus groups that we led with pregnant patients who use cannabis during pregnancy in late 2021. And the reason for this is that too often we're really conducting research on and about people rather than being inclusive of the people who are being studied. And so we wanted to include the voices of our patients as well. So for this talk, we're going to briefly go over some of what we've been seeing in trends in prenatal cannabis use. And then we're going to focus on two papers we recently published looking at the health risks in our patients. We may end there, but if there's time, we might share a few slides about what we've learned from our patients about how you can talk to them about their cannabis use during pregnancy. Okay, so what are we seeing in terms of trends? Well, when we first got interested in studying prenatal cannabis use, we had heard anecdotally that rates were increasing. Our clinicians were seeing more patients who were screening positive for cannabis use in pregnancy, but we really wanted to understand how much were they actually increasing? So this was a paper we published in JAMA in 2017. And what we found was that from 2009 to 2016, prenatal cannabis use increased from 4.2% to 7.1%. And that's this black line here. So if you say they said they were using or they had a positive toxicology test to which they consent, we would include that. But what we also found interesting is that over twice as many people were identified as using cannabis during pregnancy by toxicology tests as compared to self-report. And so one of the things that this indicated to us is that a lot of the prevalence estimates that we have are based on self-report. And so we think the true scope of use during pregnancy is likely much higher than what we had previously thought. We also looked at trends by age group. And so here you can see our youngest pregnant patients, less than 18 and 18 to 24, shown in blue and orange, are not only more likely to be using cannabis during pregnancy, but they actually had the quickest rate increase over time as well. So they were increasing more rapidly than our older pregnant patients, which was kind of concerning to us. The next question that we had about trends was whether patients were using more frequently over time. And this was curious to us because we know that acceptance and accessibility of cannabis are increasing. And so maybe pregnant individuals are using more frequently now too. And so using a large data sample of KPNC patients from 2009 to 2017, here you can see that the annual relative rates of change in self-reported monthly or less, weekly, and daily cannabis use during pregnancy all actually increased significantly over time. But what was notable to us was that the percentage who were using daily was actually increasing most rapidly. So another way of looking at this is that in 2009, our pregnant patients who said they used cannabis, 14% said they were using every single day. By 2017, that had gone up to 21% using every single day. And I can tell you that our data from 2021 show that daily use has now increased to 32%. So not only do we have many more patients who are using cannabis during pregnancy, in recent years, about a third of our patients who are using every single day. And I think this is really important as we're thinking about the potential health risks, because we've seen this extraordinary increase in the cannabis strength. So the primary intoxicant, which is THC, as you all know, has about tripled over the past few decades. And so this is really concerning. So this study was included in the US Surgeon General advisory about cannabis use during pregnancy and in adolescence, and tweeted by him and received a lot of media attention. And when we talked to our pregnant patients in these focus groups, we heard so many stories that really complemented what we were seeing in our data. So this patient says, like 5 years ago, if you smoke weed while pregnant, people would be looking at you like you're crazy. Like, what are you doing? They're like, who sold a pregnant person some weed? And now it's like you might see a group of pregnant people just passing the blunt around like, oh, okay, like y'all smoking, okay. We also wanted to understand whether rates of prenatal cannabis use might be increasing faster among patients who did not use any other substances during pregnancy. And this is as we know that people are kind of viewing, especially in California, cannabis use in pregnancy is seen as less of a concern. We thought a greater proportion of patients might be using only cannabis and who may otherwise never have considered using another substance. And this is important because, we know that co-occurring use of other substances can also make it harder to study the true health effects due to cannabis. So we were curious in looking at this, and this was a paper we published in 2022 in JAMA Network Open. Sure enough, what we found was that the largest percentage of our patients who used cannabis during pregnancy were screening and testing positive only for cannabis and not for other substances. And in fact, cannabis and 2 or more other substances was actually going down over time. And we found that the adjusted prevalence was increasing fastest among those who only use cannabis. So they were most common in that group and they were increasing faster over time. And when we looked at co-use of specific other substances, again, you see the cannabis only line, and that we found that cannabis and nicotine, cannabis and stimulants, and cannabis and pharmaceutical opioids were all going down over time, but we actually saw a slight increase of cannabis and alcohol. And I don't know if, I know people are kind of from all over. I don't know if everyone's heard of California Sober, but it's sort of this notion that people decide to quit consuming drugs and alcohol with the exception of cannabis. And when we talked to our pregnant patients, we heard a lot of themes like this. So this is really Interesting quote from a patient who was talking about cannabis use during pregnancy. He said, "I don't do drugs, I don't take cocaine, I don't do heroin, I don't do methamphetamine. Do I smoke marijuana? Yeah, sure I do, of course." So it's not really even seen as a substance. And then finally, in terms of trends, of course, we were interested in looking at the impact of the COVID-19 pandemic. We were able to secure a competitive revision to a grant that my colleague Lindsay Avalos and I had from NIDA. I was pregnant with my second son in had him in July 2020. So was right in the thick of it myself and was really curious to understand, how that impacted cannabis use in pregnancy. So this was a paper we published in JAMA and in 2021. And what we found is we used an interrupted time series design to compare the prevalence of prenatal cannabis use during the 15 months before the pandemic to the first 9 months after the pandemic. And we essentially found a 25% increase during that first 9 months of the pandemic, which is pretty striking to us. Okay, so I hope I've set the context now that we're seeing more use, greater frequency of use over time, and maybe less co-occurring use of other substances, and this jump that happened with the COVID-19 pandemic. So now let's switch into the health risks, which is something that everyone is really curious about. We think that cannabis may be harmful to the developing brain because it disrupts the developing endocannabinoid system, which really plays a critical role in shaping brain development from conception all the way into adulthood. And what we've now seen pretty consistently in the literature is that prenatal cannabis use is associated with increased risk of low birth weight, small for gestational age, preterm birth, and neonatal intensive care unit admission. There's some data suggesting that it's also associated with attention and externalizing problems in childhood, and then really less to suggest that it's associated with other behavioral and cognitive outcomes. If some of you may be familiar with the Adolescent Brain Cognitive Development Study, or the ABCD study, and this is really kind of one of our best data sets that we have to look at the long-term health impacts of cannabis use and exposure in utero. So there's 12,000 youth, and they talked to their moms after the children were about age 11 or 12 and asked them about whether they used cannabis and if during pregnancy, and if they stopped once they realized they were pregnant, or if they continued to use after they realized they were pregnant. And so what this study found was that only among the pregnant individuals who continued to use after they knew they were pregnant, there was this association with increased risk of attention, social, and behavioral problems all the way into early adolescence for their children, so around ages 11 or 12. But my colleagues and I have really kind of talked about some of the existing gaps in the research that's been done so far on prenatal cannabis use. Oftentimes, studies are based on self-reported use only, which our own work has shown is really underestimating the true prevalence of use. Many times studies are not accounting for co-occurring substance use, or if they are not adequately accounting for co-occurring substance use, and maybe only by self-report, which again, we think is underestimating co-use of other substances. Studies typically have not looked at frequency of use, and also I don't know of any studies that have really compared different modes of cannabis use administration, which is a huge gap. Some of the studies are underpowered with small sample sizes, and then many of them have older data, which is a problem because, as we talked about, the strength of the products that people are using has been changing over time. So we tried to address these gaps using our data. So I'll tell you briefly about two recent studies that we conducted. This one was published in American Journal of Obstetrics and Gynecology earlier this year, and it focused on neonatal outcomes. So for this study, we used a very large sample of pregnancies in KPNC from 2011 to 2020. These were pregnant individuals screened by self-report and urine toxicology tests for prenatal cannabis use. And we looked at any use. So if you said you used, or if you had a positive toxicology test, we kind of think this is our best information that we have. We considered you to have used. And then we also looked at frequency of self-reported use. So for this study, our outcomes were low birth weight, small for gestational age, preterm birth, neonatal intensive care unit admission, and whether the baby required respiratory support. In our analyses, we conducted generalized estimating equation models that accounted for multiple pregnancies per person. So we allowed people to be in the sample more than once. It was, from 2011 to 2020. So some people were repeated, but we accounted for that in our analysis. This is just a breakdown of our maternal sociodemographic characteristics for you to see. So the sample was pretty diverse in terms of race and ethnicity. And you can see that most patients were 25 to 30 years old or 31 to 35 years old, but there was some variability. And the percentage of pregnant individuals who's doing positive for cannabis overall was 6.2%. All right, so I know this is a lot to see, but I just wanted to show you. So these are kind of our overall findings for this paper. And what I'm showing to you is the percentage with cannabis use in those whose moms had screen positive, the percentage with prenatal cannabis use, and then the percentage without prenatal cannabis use, and you can compare the outcomes. So among people whose moms had used cannabis in pregnancy, for example, 6.6% had low birth weight, and among those who didn't use, 4.8% had low birth weight. So that's how you can kind of look at the left side of this. And what we did is we ran a number of models in steps. So we wanted to look at whether adjusting for different covariates had an impact on our findings. So basically, we just put things in that we thought could be covariates in a stepwise manner, with model 1 being unadjusted and model 5 being our final model, where we kind of threw everything that we had into the models. And so we adjusted for a wide variety of things, including a bunch of sociodemographic characteristics. We included self-reported use of other substances during pregnancy and positive toxicology tests for other substances during pregnancy, which is a strength compared to many of the prior studies that have been done. We also looked at prenatal care, and then we included a number of medical and psychiatric comorbidities that could potentially be confounders in our final models. And so what you can see here in model 5 is that we found that maternal prenatal cannabis use was associated with significantly increased odds of a low birth weight baby, a small for gestational age baby. It was almost significant for early to moderate preterm birth, which is more severe, so less than 34 weeks gestation. And we did have a significant increased risk of preterm birth defined as less than 37 weeks gestation. We also found increased risk of the offspring going to the neonatal intensive care unit, and no significant association with respiratory support. We also looked again at the frequency of self-reported use and whether there was kind of a dose response association with frequency. And we did identify statistically significant trends for low birth weight and small for gestational age. So there was an increasing likelihood of low birth weight and small for gestational age associated with increasing frequency of maternal cannabis use during pregnancy. So here you can see that the greatest odds were associated with daily use during pregnancy compared to monthly or less, compared to no use. But the association was less strong than it was for monthly or less use compared to no use. Okay. So I'm gonna, I'll take questions on both studies at the end, but I'm gonna switch over now to, this was a paper that we just published in JAMA Internal Medicine on Monday of last week. And this was a very similar design, but instead of looking at neonatal outcomes, here we were looking at maternal pregnancy outcomes. So I won't spend a lot of time, the methods were very similar. Again, it was a large sample of KPNC patients. We looked at any use, we looked at frequency of cannabis use during early pregnancy. For this study, our outcomes of interest were hypertensive disorders. So we looked at gestational hypertension, preeclampsia, eclampsia, gestational diabetes, gestational weight gain, both above and below recommended guidelines. And then we also looked at placenta outcomes, and we looked at severe maternal morbidity. So for this analysis, we used extended modified Poisson models with robust standard errors that accounted for that we allowed multiple pregnancies per person. And for these models, we adjusted again for a large range of covariates, including maternal sociodemographic characteristics, other prenatal substance use, adequacy of prenatal care, and then maternal, medical, and psychiatric comorbidities, and antidepressant medication use was also adjusted for in both papers. And I want to just show you, so for in this sample, again, 6.3% screen positive for cannabis use during pregnancy. And then here, again, we're seeing a higher percentage who are positive on toxicology testing as compared to positive on self-report. And about 1.8% of our patients were actually self-reporting use and screening positive by toxicology tests. And we've published validity papers before showing really the best, most accurate information is if you combine the toxicology test results and the self-report. So here, this is across years, 0.6% of our samples said they use daily, 0.7% weekly, and 1.5% said they use monthly or less. And the editors of this journal actually asked us not to present all 5 models where we entered our covariates in various steps. They said, just show us the unadjusted and the adjusted. So here we have 2 models, but we actually conducted it in the same sort of way as we did the first paper, with model 2 adjusting for all of those potential confounders that we have talked about. And so what we found in this paper was that maternal cannabis use during early pregnancy was associated with an increased risk of gestational hypertension, increased risk of preeclampsia. There was a signal that it was, for eclampsia, but we had so few, it's such a rare outcome, it was not statistically significant. So we might be, kind of onto something there, but it would take a very, very large sample to have power to have a significant finding for there. We found an inverse association with gestational diabetes. So there was actually lower risk of gestational diabetes associated with prenatal cannabis use. And then we found increased risk of gestational weight gain below recommended guidelines and above recommended guidelines, and just more likely to be out of the range that's recommended. And then we found a significant increased risk of placental abruption. The other placental outcomes were not significant, and we did not find a statistically significant association with severe maternal morbidity. When we looked at frequency of use and kind of tried to see if there was a trend, we did in fact find that there was greater odds of gestational hypertension with increasing frequency of use. So those who used daily, their adjusted risk ratio was 1.24. Those who used weekly was 1.21, and monthly or less was not significant at 1.03. So this was the one outcome where we really did seem to see sort of dose response effect with frequency of use, but there were no other kind of evident trends from our data. So taken together, these 2 studies, I think our work improved upon a lot of the limitations of prior studies. So we had a huge sample. We had universal screening, so we're not cherry picking who we think might be using and then screening them based on clinician judgment or anything like that. Just universal screening by self-report and toxicology testing done for all patients as part of standard prenatal care. Our study included more recent data. We were able to examine frequency of use. We adjusted for a bunch of covariates that are available to us through our electronic health record because we are an integrated healthcare delivery system. So we have information on all of these other things about the moms, including comorbidities and other substance use during pregnancy. And then one thing I didn't mention, but we did for both studies, is we conducted a large number of sensitivity analyses. So we did things like, we had a large enough sample size to remove anyone who had used anything else, any other substance besides cannabis. So we were adjusting for other substance use in our main models, but then we said, let's take it one step further and just see what happens if we take out anyone who also used other substances and just look at a cannabis-only group. And even in that analysis, we found very similar results. So that kind of increases our confidence that our results are not really due to co-use of some other substance. And then we also looked separately by screening methods. So we looked among those who screened positive by toxicology tests, what do we find? And among those who screened positive by self-report, what do we find? And the results were pretty consistent regardless of the method that we used to, to measure cannabis use during pregnancy. We have some limitations. So our patient population are insured patients in Northern California. So it's very possible that our results are not generalizable to uninsured patients or to patients in other states. In California, cannabis has been legal for medical use since 1996. We were the first state to legalize medical cannabis use, and we legalized adult use cannabis or recreational cannabis in 2016 with adult use retailers being allowed to open in 2018. So kind of that's context is all happening here as well. When we're talking about prenatal cannabis use in our work, we're talking really about cannabis use during early pregnancy. So again, this screening and toxicology test is occurring at entrance to prenatal care. It's about 8 to 10 weeks gestation. It's not always early, so someone who comes into prenatal care in the 3rd trimester for their first visit will get this screening. And so some people may be farther along when they're screened, but for the most part, it really does reflect use during early pregnancy. We do not know whether some of these people continue to use or whether some quit. And so that's another limitation and something that we wish we had the data to examine. And we may actually be able to do some of that in the future. But for these years of study, we just don't know, whether the results might be driven by people who really use their whole pregnancy. Because remember the ABCD study that found that the association only remains significant in the subset of pregnant individuals who continue to use after they knew they were pregnant. And the way that our screening is done, it captures any use during pregnancy, even if it only occurred before pregnancy recognition. We also didn't assess for the strength of the cannabis products or the products used or the reasons for use or the modes of administration. And while we attempted to adjust for a number of confounders, kind of everything we had our hands on, it's always possible that unmeasured confounders may have impacted our findings. So this is part of a series of studies. So we have some next steps. We're looking at currently at fetal loss, at birth defects, at offspring developmental delays, and also at offspring psychiatric conditions to see whether those things are associated with maternal cannabis use during pregnancy. One of the major limitations that I've already mentioned is that studies haven't been able to differentiate the relative risks associated with different modes of cannabis use, which is really important and something that our patients are asking us all the time, and we just don't have any data to give them. And so we were able to work with our early start leaders and our operational leaders to actually start screening our pregnant patients for their mode of cannabis use during pregnancy in 2021. And so we're collecting those data. We've published some initial pilot studies, and we now have another NIDA large grant to actually examine how does mode of prenatal cannabis use relate to these other things we care about, like other substance use in pregnancy, maternal health conditions, and also the local policy and cannabis retail environment. So I have about maybe 5 minutes on what we've learned from our patients about how they would like their clinicians to talk to them about prenatal cannabis use. Caitlin, should I stop here or would you like me to keep going?
No, you're welcome to keep going.
Okay, great. So this will be really brief, but I think it's important. Through our work, with focus groups and talking to many patients who use cannabis during pregnancy, we've come up with some recommendations from what our patients have actually told us that they would love from their clinicians when talking to them about this topic. We know that pregnancy provides a really unique opportunity to provide care for patients who may otherwise not be seen by a physician. And pregnant individuals are so motivated to improve their health behaviors for the benefit of their baby. We also know that pregnant individuals are looking for information about the risks associated with prenatal cannabis use. They're asking, they're trying to find out. A lot of them believe that there are no harms. And some studies have shown that when patients do try to talk to their clinicians about prenatal cannabis use, a lot of times clinicians don't really respond or don't have any information to give them. And so many patients are going online, they're asking friends and family, and they're receiving a lot of kind of incomplete information suggesting that cannabis use during pregnancy is safe. And so I just want to reiterate, the goal of our work is really not to try to scare patients or make them feel badly, but to give them the information that they themselves are asking for so that they can then make more informed decisions around whether to use cannabis during pregnancy. And I just wanted to mention, because there's a whole other body of work we've done showing that people who use prenatal cannabis use are more likely to have prenatal depression and anxiety and nausea and vomiting in pregnancy and psychiatric and substance use disorders. And we've heard so many times from our patients that they're using cannabis as a way to try to self-medicate all of these other things that are going on with them. And they really, in fact, sometimes feel like they trust that the cannabis will be a safer or more natural product than whatever it is that their physician would prescribe to them. They trust bud tenders who sell the cannabis at cannabis retailers and kind of view them as doctors, even though they don't actually get any training whatsoever in California to be a bud tender. And so I'm saying all this because I think it's important to remember that it actually, a lot of our patients are being bombarded with this information, telling them that cannabis use during pregnancy is safe. And so here are the recommendations that came out from our patients about what they would like when they're talking to their clinicians about prenatal cannabis use. This was a paper published last year in Obstetrics and Gynecology by a fellow, Tara Foti, who was working with me. And the first recommendation that our patients really kind of came out from talking with them was that they want their doctors to ask them about their cannabis use during pregnancy, to be curious, to really recognize that they have their reasons for using, and they want their doctor to try to understand them. So this patient said, teach doctors how to bring cannabis up in a way that isn't judgmental, just an open, confidential conversation with your doctor. There's no judgment here. The next recommendation is to really listen. Hear why your patient's using cannabis during pregnancy, rather than just saying, don't use, all use is bad. We heard from patients that they're experiencing benefits, and the second that their doctor just says it's all bad, there's, just don't do it, they stop listening. And so this patient says, I want to explain to my doctor what the cannabis benefits are and why I prefer it over prescription she wants to give me for my pain. It's really important to have a dialogue. So our patients want it to be a real conversation and not just a lecture. And this patient said, my doctor asked a lot of questions and listened and made me feel very comfortable. They want their perspective acknowledged. So it's really important to reflect back why they're using and acknowledge their perspective before going on to provide all this education and advice to quit. So this patient said, know that whatever choices I make, I use cannabis because I believe it's the best choice for myself. And then sort of once we've asked and listened and had a dialogue and acknowledged our patients' perspectives, then we can really provide education in a way that our patients are going to be willing to hear what we have to say. And so then at this step, just to provide non-judgmental education. And this patient says, give me the health benefits of it and the cons of it so I can make an informed decision on my own. And then finally, of course, recommend quitting. For patients who are not willing to quit, provide alternatives. So suggesting to use less frequently, or maybe to switch to non-smoke products or to not co-use with tobacco are all potential things that you could tell your patients. And then provide alternatives and referrals and resources and other options for patients who are using for mental health reasons or to try to self-medicate their nausea and vomiting in pregnancy. So with that, I just want to acknowledge all of our collaborators who've helped with this work. Our funding sources, the National Institute on Drug Abuse has funded a lot of this work. And I will go ahead and end there. So Dr. Deb Ansley is also on this call, and she is the OBGYN who is the medical director of our Early Start program. And so she's also here to provide her perspective and answers to questions as well.
Great. Thank you so much, Kelly. That was wonderful. Thank you so much for going over all that great data. And I love the ending with the patient voice at the end. And thank you, Dr. Ansley, for joining us today. We've had a couple questions in the Q&A. If you have any, please put them in the chat. And then after I go through a couple, then we will open it up to if anyone wants to speak up. Our most recent question is kind of going off of what you were just talking about, Kelly, which was about discussing best practices for discussing the pros and cons, risks and benefits, however you want to state it, of antiemetics versus cannabis in the setting of nausea and vomiting of pregnancy. I think that's a common clinical situation that a lot of us come in. So based on your work, the qualitative work, and also the quantitative findings that you've had, do you have any pearls or tips and tricks that you could give this audience for that specific topic?
I'll let Deb start and see if she has anything she want to say, and then I can and chime in about some of the things that we've seen in our data too.
Yeah, I think it's really important to talk to the patient about nausea and vomiting. It's a common thing, and you have to remember that sometimes when you stop cannabis use, you'll have worsening nausea for a little while. And so, really being open with the patient and helping them to understand that it might even be 2 or 3 weeks before that gets better, but that the cannabis may actually be the source of the nausea and not just the pregnancy. So again, it's being educated about that and understanding that that may be contributing to it and being able to kind of explain that to patients, so that it helps them to understand that you might have to put up with it. It might get a little worse for 2 or 3 weeks, but then it may be better for the weeks or months that follow and the remainder of the pregnancy. So you have to be real open about that. We have a great phrase that we share with patients about things you can do naturally to treat nausea. So we often recommend just B vitamins, vitamin B6. We have other medications like Unisom that has been used for many, many years that we have safety information on. And we also just share lots of natural things like saltine crackers when you get up, acupressure, C-bands that they can put on their wrist, using ginger pops or ginger in other ways. So lots of natural things that we always recommend trying first. And then reminding them that though cannabis may seem like a natural substance, alcohol comes from a natural substance, heroin comes from a natural substance, right? Those are all natural things, but not things that we would recommend or think are safe in pregnancy. So just being non-judgmental, but answering their questions honestly and being informed yourself so that you don't get kind of bobbled up or uncomfortable with the conversation, so that you can stay in that non-judgmental place, but provide really good supportive information for them to understand.
That's great. Thank you, Deb.
And I'll just echo,
Mhm.
having published papers like yours, Kelly, just having these numbers too, and talking to our patients about, hey, this study came out, there's some limitations because we can't do these really big trials in patients, but this show that there might be an increased risk for, small for gestational age, low birth weight, et cetera, with first trimester exposure, and giving them those numbers from your paper can be very empowering for us as clinicians. So I'll kind of just add my 2 cents to that discussion about using data and how it can give us power as clinicians to empower our patients thereafter. Another
Well,
question.
and I will add, it's also really great this last hour. I'm sorry to interrupt, but I gave us even more power to give explanations, right? Because people used to hear, oh, my baby will be small. Yay, that's easier to deliver a smaller baby. And they don't really understand the implications of small for or low birth weight, and that's not a good thing even at the time of birth, but certainly not even for that child's future of what that means about their cardiovascular system and things like that. So really, having more things to say, this could increase your chance of, having your baby early, your placenta tearing away, getting elevated blood pressure, or just, through gestational hypertension or preeclampsia, really gives us a little bit more weight to say there's a lot of things in your pregnancy and then for your baby as well that might be harmful. So again, not being scary, not trying to be threatening or judgmental, just say, I always say to my patients, I'm here to give you information. You're here to take that information and do what's right for your body. It's your body, your decision. I'm just the person here to educate you.
Yeah,
Yeah,
excellent.
and I would just add, it's interesting that so many more studies have been done on the neonatal outcomes and the outcomes for the offspring later in childhood, and so few studies have been done on the maternal health outcomes. And so even in doing this paper where we're trying to emphasize that these outcomes matter, and they're also associated with poor outcomes for the offspring as well. But there was pushback even from reviewers about, this isn't enough on its own. You need to add in the neonatal outcomes. And so we thought that was really interesting. Again, so we've already published the neonatal outcomes, but we think that these outcomes for the maternal pregnancy outcomes are also important. So yeah.
Yes, very much so. We had a question earlier in the discussion. It was kind of a specific question, but I think it can lead on to a greater discussion about the sample and about comorbid mental health conditions that patients may have. I know in your paper you have in your table one about other mental health conditions in the first prenatal care visit, and it looks like 0.7% had that, and that was in addition to the mood and anxiety disorders, which was 4.1%. Our question specifically was about ADHD. So I didn't know if you could just give some insight into these numbers when we're looking at the comorbid mental health conditions in your papers, and the differences between the two groups, that something that we can glean from that in a clinical context.
In terms of whether the pregnant individuals who used cannabis were more or less likely to have ADHD, is that?
The question was specifically about ADHD.
Yeah. So that's interesting. We are doing another analysis right now that it's actually under review, where we're looking at maternal cannabis use during pregnancy and the risk of ADHD in the child, like later. And for that, we were kind of doing a bunch of work with stratifying based on different things. And we did include a focus of maternal ADHD there. And we do find that the pregnant individuals with their own diagnosis of ADHD were much more likely to use cannabis during pregnancy.
Did you include the family, the father too? Again, as a genetic disorder, we see a lot of things that I think we're born with the ADHD. So I don't know if we have an increased use with cannabis, like you said. Just wanted to be expansive enough to include as a genetic disease that everything's included.
Yeah, that's a great point. And for these studies, we have not included data on the father's diagnoses. So yeah.
Definitely,
Thank you.
definitely an interesting area for future investigation, I would say.
That's a great idea. We could at least have a subset of patients where I think we would be able to link to dad's information, but they would have to be a member of KPNC too, and not everyone has a partner and all of those things. So, but for some patients, I think we could.
They would also have an increased nicotine if they had ADHD too. So that combo may have play. I don't know.
Yeah, that's great. So there's been some other studies that have also not just adjusted for nicotine use, but looked at these interactions with cannabis and nicotine. So are the risks greatest in people who are using both? So I think that's a really great point.
And that's where the mode use study eventually will be helpful, because some people in blunts are using both, and yet they might not necessarily report that they're using nicotine. Might just assume that's cannabis only, but then when we ask specifically, is it an edible, is it a blunt, is it whatever, it hopefully we'll get more information about that.
Yes, that's great. So in our mode study, and when we started screening of all our patients for modes of use, we included a discrete question about blunt use, even though it's not really a mode. It's smoked is the mode, but we wanted to learn about this so much because of, like Deb said, the potential risks of using the tobacco with the cannabis. And in fact, we have patients who are saying yes to that question who don't endorse smoking. So anyways, I think we're getting some people we might not have captured otherwise.
Great, thank you. Our question from Loretta Finnegan is she was referring to how you discussed some older studies that you were referring back to. And so she was just curious how your data may differ and your findings may differ from prior work. And maybe you can lead a little bit in discussion of reasons why some of, we see a lot of published papers on cannabis exposure and outcomes, right? And maybe some tips and tricks in this discussion of this question you could give us, Kelly, for, well, when we're reading the papers, and using observational data, what are some things as clinicians, we should be kind of looking out for to kind of say, this is a good study, this is maybe not a study I'm going to take home and change my clinical practice. I think you get where I'm coming from with my question.
Yeah, thank you. So the older studies have kind of been all over the place, not super consistent. So some would, and they mostly have been done on the neonatal outcomes. So some would find increased risk of these outcomes and others wouldn't. But now there's been enough meta-analyses that have pulled together all of these older studies, and they are, the meta-analyses are coming out saying, like, yes, taking all of these things together, we are seeing greater risk of neonatal intensive care unit, low birth weight, small for gestational age. And preterm birth. So our results for the neonatal outcome are very consistent actually with what this body of prior research has found. Fewer studies have been done on maternal outcomes. So ours was the first looking at several of these, and other studies haven't done that yet. So those are need to be replicated for sure. But I think when you're looking at studies, I would look for a large sample size, because we think the signal is there for eclampsia, but even with our over 300,000 patients, we had so few people with this outcome that we weren't able to, that there was no way it was going to be statistically significant. And so I would look for very large sample sizes. I think, I've mentioned this before, sometimes all we have is self-reported data, and in places, where substance use in pregnancy is criminalized, we would not want to have universal toxicology testing, but I think the addition of that in our data set is actually a strength. So that's something else. And then the other thing I think is just appropriate adjusting for confounders. And one of the most important ones, although maybe less important as fewer people who are using cannabis are using other substances, but is to really be able to properly adjust for other substance use during pregnancy and other potential confounders. And so I think those are the main things that I would be looking for.
Thank you. I'm going to open it up if anyone else has any other questions they want to put in the chat, or you're welcome to unmute. Well, I have one more question and then we'll end after that. How about that? So kind of going off of my prior question, I think you can see my theme. When we're taking data like from your papers and we're looking at the adjusted odds ratios, and the confidence interval is like 1 to 1.3 or something like that. How would you recommend that we take those numbers and talk to patients about those numbers? Like if you have any pearls for that.
Yeah, I can comment on the effect size of most of these results is pretty modest. So it's that, I think we can say with a modestly increased risk. I don't know, in patient terms, I'll let Deb talk about how that might translate into talking to a patient, but we're not seeing huge, you have 4 times greater odds of this outcome. And so I think it's also important not to overstate the risk, because that's also when our patients start to tune us out, when they just think, oh, you just are anti-cannabis, and so, you're just trying to scare me. But I don't know, Deb, if you have thoughts about how you would kind of take an increased risk ratio of 13% and translate that to a patient.
Yeah, I think the most important thing is, and it's hard to remember exact percentages, but to kind of developed a script for yourself based on those percentages, right? On what the actual percent is, like 17% increased risk of preeclampsia or whatever say it is, and then allow patients to say that. And I think it's fair to say, that's not a huge increased risk, because they're going to say often, I've had so many friends who've used cannabis the whole time and they are fine and their babies are fine. And it's important to say, yes, that is true. Just like many people might smoke their whole life and never have a disease associated with that, but many others do. So whenever we're looking at things, we're putting them on a scale and we're weighing risks and benefits. And this one should just, weigh a little bit more toward risks than benefits at this person. But again, for these reasons, but again, it's a personal decision, because I don't think we want to be inflammatory, and we don't want to say, no, just don't do it. Right. We want to provide people with good information, but at the same time, we want it to be real, right? That, there is an increased risk of all of these different things. It's not just one thing. It's not just small for gestational age that we used to be able to say based on the big meta-analysis that was done, and the only one we could really prove. Now we have, multiple things. It's not just small for gestational age. It's NICU admission, which might interfere with bonding and you being able to stay with your baby after the birth, because the baby may need to go to the nursery and you'll miss that initial bonding time and breastfeeding time. It's, being born prematurely. So your baby comes earlier and has to spend, a few days or a few weeks in the hospital. It's, has health implications for you if you develop gestational hypertension or preeclampsia. That has impacts on your future cardiovascular disease risk. And we're not just worried about the baby, we're worried about you as an individual and your ongoing health moving forward. So I think just being really comfortable and having kind of your script of what you say, and knowing a little bit about the percentages, and saying, like Kelly said, there's a modest increased risk. You may not see that problem. You may have your baby full term. Maybe, you may not develop any high blood pressure, because remember, they're probably going to get pregnant again. And so, and none of those things may happen. but they may, right? And so it's about, being comfortable with the risks that you're taking.
Well, thank you both so much for coming today and presenting. Thank you so much. Applause at our WAG Journal Club for both of you. I appreciate you guys coming and giving numbers and data. I think a big mission that we have from this aspect of the WAG group is, providing our team with numbers to drive change. So thank you so much. Just last shout out just for and everyone's email, the save the date for October for the meeting coming up for our group. And thank you both again, and we'll see everyone soon for the next WAG Journal Club. Thank you. Have a great day, everyone.
Thank you. And feel free to reach out to me after this with any other questions or thoughts. I'd love to hear from you. All right, take care.
Thanks so much.
Thank you,
Great
everyone.
work. Take care. Bye-bye. Thanks, Caitlin.